Welcome to a short film about what we would like you to know um, when you're dealing with people with dementia, dealing with in the broadest sense of the word. We are three people living with young onset dementia, although we're no longer young, I'm afraid. And Susie cared for her mum, who had dementia for several years, many years, I think. And who died a year and a little bit about ago. Okay, so I think let's start off with the good. Who would like to start? Yep, Martin.
I I went into to the consulting room thinking I had something else totally different. I came out with a diagnosis of dementia, and by the time I got to the car, I was jumping up and down with joy. And the reason for that was I was told not to drive, so I had to give up work.
Yeah,
And I felt that I didn't feel bad about not driving because I knew my driving wasn't perfect. But equally, I just thought it was my eyesight. But actually, I have a rare dementia, posterior cortical atrophy. It can be called brain blindness. You can see I've closed my eyes, so I concentrate on talking and listening. So that's the way I try and look at it. That basically I do what I want when I want. There are times I overdo it. Like yesterday, I was in the garden for about an hour and a half, and I was in bed by 6 o'clock
yeah,
because I'd overdone it. But that's my fault.
yeah.
So that's how I would see it. But that's the good part is that you can do. You're free in a way, no longer tied to
You
the.
know, you no longer have to follow convention all the time.
Yeah.
Do what you want. Yeah, Julie. Any thoughts
Hi,
from?
I had gone through, as with a lot of people with young onset, it takes a lot longer to be diagnosed, and I'd gone through a patch of over 5 years of experiencing severe difficulties of some kind, but it never been diagnosed. And having been unemployed, I'd lost my job as a social worker because of the difficulties I was having. But so when I got my diagnosis, instead of it being a negative for me, although it's not a great diagnosis to have, it actually became a positive because I had an answer. And then I could focus my life and I could actually start doing things. So instead of being long-term unemployed and feeling on the scrap heap, I then started looking at what I could do using my life skills that I built up, and so went to starting up my own young onset group, and then getting involved in things like research and so on. So it's very much about what we can still do, and also making use of those past life skills. Um,
I think that's a really important point that we all have been working,
mm,
and for that matter, living. We have loads and loads of what I would call just general wisdom, but we also have a lot of skills, and we want to go on using them. So when I was diagnosed 10 years ago, I was 64, and I had pretty much given up work because I just couldn't handle it anymore. Um, but since that, and after the first couple of years, I started rather like Julie, doing things like starting deep groups, and a deep group, and I joined in the sort of sense of work with the deep network. Um, I I've learned to paint. I love gardening. I love being outside in nature. I enjoy reading, although I find it more and more difficult to get through a book. And in particular, as a result of having dementia, I have made some incredibly good, close friends over Zoom. You know, I've got friends who are virtual. I mean, I know they're real, and I meet them occasionally, but we met so often during COVID that we became really good friends. And I miss that actually now. because we don't meet as much. Let's
Can I
good.
jump in
Go
a
on,
bit
yes.
and say I am now actually employed? Sorry. Amazingly enough, I retired. I got my state pension last month, and within 2 weeks, I got an employment contract with a university as a researcher.
Yeah.
Based on my lived experience. So you can still work even after you've got your diagnosis.
Absolutely. Yeah. I also do paid research with, I think at the moment, 3 university projects. The thing about doing this stuff is that it gives us our identity. It gives us who we are. It allows us to continue to know that we can influence the world around us, and we can make things better. Martin.
And I'm going to trademark this phrase. I call it catnip to the brain. My brain needs it as much as I want it. For instance, during the Christmas holidays, my brain does atrophy a bit because I don't have such work to do. And my neurologist actually said, without it, I would have been in care years ago.
Yeah.
So it's not a treatment, but it certainly helps.
Susie, you want to say?
Yeah, I just wanted to say you're sort of reminding me of when my mum was diagnosed. And my mum was diagnosed when she it took us 10 years to get her diagnosis. So she started seeing the symptoms in her mid-50s, and she was diagnosed age 65. And what I noticed very soon after her diagnosis was that people started talking really slowly and really loudly at her. And I, on a couple of occasions, had to say to medical professionals, social care professionals, my mum's not deaf and she's certainly not stupid. And like with that diagnosis, the way people changed towards her was incredible. And how we would walk into a medical assessment together, and the professional would talk to me, not my mum, like she wasn't there, like it didn't matter that, you know, and that just sort of bringing that up really into the conversation of, you know, what's important to you in those situations where you're meeting health and social care professionals. What are the things that really help you get person-centered care?
I totally agree with that, but with me it's the opposite. I can't take in what anyone is telling me because the lights will be too bright. Even if they're switched off, they're still light. And I'm afraid I do have to take Ethel, my wife, with me, and she'll tell me later when it's calmer and I'm calmer.
Yeah.
I totally agree with what you're saying, but everyone with dementia is different in every single way you can think of.
Exactly, yeah.
And I think,
afraid.
Martin, what you're talking about there is person-centered care. Is actually, isn't it? You know, what works for you is what matters and what gives the best outcome.
So see the person, not the disease. That's the classic, isn't it? Julie, what do you want to say?
Yeah, I mean, I am on my own. So, and I don't have any involved family. So when I've gone along to appointments and things, then they kind of have to speak to me because I'm the only person there. But I do get a sense sometimes of when I'm speaking to them that their eyes glaze over a bit. They're not really listening. It's kind of, yeah, right. And at the moment, because of certain medical issues, I'm having to go through going back to my doctor again. And what I'm finding is that trying to get through to them, having various tests done, they're not communicating with me. They've spoken with a good friend of mine. They've spoken with my social worker. But you know, occasionally I'll get a text message through, but I'm not getting the full information. So I have to get someone to ring up for me and say, can you speak to Julie? Can you let Julie know what those test results were? So it's very much a kind of, like I say, always coming back to the person, because we remembering that we can still understand and we can still carry on a conversation. And even if someone is having difficulties in understanding, you can put things in a simpler way, not by talking slowly and loudly,
Yeah.
but you can put things in a
Avoid the
very
jargon.
avoid the jargon, put things in a simplistic way, and if they need someone to be helping them retain that information, then that's fine.
Well, one trick that I know someone uses is to take a piece of paper and a pen and ask the doctor to actually write down, or could be anywhere, nurse, whatever, to write down the key things they want them to take away. Because otherwise, we might easily forget, within minutes of walking out the door. Some of us might, not all of us. Martin.
I had a horrendous experience last year because I had to go and get some dental treatment at the hospital. The consultant saw the D word and said, "Mr. Robertson, I'm going to have to section you under 42 of the Act because there's a choice of treatments and you're not capable of it." Once I came off the ceiling.
I'm still up there.
She did say, "Oh, you do sound fairly as if you've got your medical," because she was looking at the Medical Capacity Act, obviously. So she said, "What we'll do is we'll check when you come back if you know the name of the Prime Minister, etc., and all that stuff they normally do." And I actually put in a complaint, and they actually did listen, to be fair, because obviously with my condition, if you're in a dentist again, you've got that bright dental light on you.
Oh God, that'd be awful.
Yeah.
So they learned kind of the next time I went in, it only went on for whenever they actually needed to use it and things like that. And they didn't bother asking me who the Prime Minister was. Who at that time you wouldn't know whether it was Truss, whoever at that point.
Yeah.
There is a certain tendency amongst some social, health, legal staff who sort of assume that because you've got a diagnosis, you can't have the capacity to consent to whatever you want done, which is nonsense. And they should, if they're really seriously in doubt, they should assume that I do have capacity, or anybody else for that matter, until I demonstrate that I haven't.
And that's the thing that legally, from having been a nurse and a social worker, that you have to legally assume capacity unless you have proof otherwise. And the fact that even when someone has lost capacity, as we all know, is quite a fluid thing. So that someone might be more fluid, have more capacity at a part of the day than they're doing in another part of the day. That they might
days, different weeks, whatever.
And different medications might affect them. That if they've got something like infection or some other influence like that.
The other thing I'd say about capacity is, on the assumption that I have got capacity, if I make a decision that you don't think is a good decision, it's nothing to do with you, it's my decision. The only time anybody else should get involved is if I decide to do something which is quite clearly and obviously a risk to myself or someone else.
And we shouldn't become too risk averse, because we're allowed to make decisions which are still others might not think is a good idea. but there are our own particular risks that we might decide, oh, I don't want people coming into my home to take care of me on a very regular basis, or I don't want yet to move into a care home. I do realise that that means that that I am at a certain risk of falling, for example. But it's my risk. I do realise what the consequences might be,
Yeah.
but just for now, I've decided it's not what I want.
Yeah, I find that I'm always treated like a series of numbers, tests, data. I am a patient. I'm not me. People do not ask me and listen to me about what sort of day I'm having or what I would like to do. No one, in terms of a care plan, has ever sat down and talked to me about a care plan that includes what I want to do in life. Care plans that I've ever seen from the memory service, for example, have just been a series of numbers. And that's it. Yeah, Martin.
2 points. The first point is to get good, not care exactly, but good relationship is to have a very rare dementia. Because every time I go anywhere medical wise, they're always wanting to know how it's affecting me.
Yeah.
And because again, because I'm doing all this work, my cognitive functions are a lot better than my physical bits. I'd say I'm falling apart from my brain. So I'm able to tell them a lot more than other people at my stage would normally do. So that kind of every time I go and see, say, my neurologist, there's at least 5 students hanging on every word I say.
Yeah.
So that's good, and that's kind of. But the bad part of that is I got a care manager in to see what I could get, and because I was quoting Mental Capacity Act and all that stuff to her, she said, "Mr. Robertson, you're lying. You're trying to get free personal care because up here in Scotland we get free personal care." My wife had to run out of the room in tears. I stormed off and got a diagnosis letter and said, "Well, I think you better go now." So dementia is not even primarily about memory loss and cognitive loss, really. You've got to accept that dementia can affect many parts of you.
Yeah. And that's a really good point, actually, to make to everybody. Memory services are called memory services for no reason other than no one wants to call them dementia services or brain health services. But what we're talking about is disease which can affect any part of your brain and which therefore can affect any function at all. So, I find balance quite a problem. And I used to find word finding quite difficult. Julie.
Yeah, absolutely. The whole stretch of the symptoms that can affect us, that increasingly for me, word finding is an issue. For me, during my dementia journey, that I always expected, even given my professional background, that it will be memory, it will be cognitive issues first, and only during the very end stage would it be physical symptoms. But actually, I've had mostly physical symptoms so far. Yes, cognitive, but for example, I have very little balance now, so I can only kind of wobble around my home when I'm walking for it. But when I go out, I need to be in a wheelchair. You should always make sure that people have a care plan. I've never had a care plan, or it's never been shown to me. Make out the care plan with the person. Otherwise, you're never going to be providing person-centered care. And also, I've just started accepting carers in a couple of times a week, and that I always found really quite hard to accept, allowing someone into my home to give me a bit of help. And it made me really, really nervous about that. The ladies who are coming into me are really lovely. But I know that I've had friends who've had experiences of sometimes their home carers coming in, and because they're coming into someone who's got dementia, they're coming in, right, and they say it's their job to organise their home. Oh no, this isn't tidy enough. I'll put this, and this everywhere. Well, for us, quite often, because of our ability to remember where something is in our
Oh, yeah,
home,
yeah.
that things might not look as tidy as you would like it, but if someone comes around and decides to tidy up, I'm sorry, but I'm likely to never find that again. So, please don't do that for me, or, only
Well, it's back to,
don't put something somewhere.
it's back to treating us as we are.
Yeah.
Simply, we are who we are. We live our lives as we live our lives, just like everybody else. And if we need help, it is to help for us to live our lives, not the life someone else thinks we should have.
We might, for a long time after I got my diagnosis, my son-in-law, who just lived down the street, couldn't see me as having dementia because we do family quizzes every week, and I was coming tough and everything, and I was full of fun and jolly. But the minute he went out the door, I would go and collapse in my bedroom.
Yeah.
So I discussed it with Ethel, my wife. She said, yes, but the problem is you put it on a face.
Mm-hmm.
That is
this was even to someone close to us. So now he accepts it, because if I get tired or whatever, I'll just say, excuse me, and I'll go away. But I think a lot of people with dementia do put on a face, settle in public.
Yeah. Something Susie said, maybe she can explain it, about and what else? And what else? Just say that.
Yeah, that really helped us as a family. We, after many years of not getting a lot of support from the GP, we had a new GP start at the surgery who came to visit us all at home. Because I was then living with my mum, dad, husband, and 2 children, and we all had all sorts of things going on for us. So GP said, I'm just going to come down. I'm going to come down and spend some time with you as a family. She was with us maybe about an hour. She's, what is it that we can help with, particularly about mum, obviously. And the reason I called in the first place was mum had recurring chest infections. That was looked at, and then the GP would say, what else? And I said, oh yeah, well, while you're here, could you just check mum's ears, because I don't think she's hearing as best, because she's always had lots of wax in her ears. And so the GP, yeah, sort that out, have a little look in her ears. What else? And it took that question for us to feel like it mattered. So that we could then say, actually, my dad's struggling a bit with this, with the situation, or we're having, and it just became a really lovely conversation. And it was all because of that what else, because I was thinking, I don't want to waste anybody's time, and so yeah, that what else question, or just tell me a bit more. That's what opened up the conversations for us.
Yeah, that's really good point to end on. I think that's excellent. Thank you all very much, and we do hope that if you've been watching this, you are going to take away some good learning points from there to spread amongst other people and to use yourself. So, bye-bye.